I'm grateful to the NEI for the opportunity to present what was discussed at the town hall, which, as you just heard, took place at Arvo just a few weeks ago. Many of us realize that translational research, the transportation, let's call it, or transformation of basic science findings from the laboratory to the clinic, it often works, but it also often fails. One of the reasons why it fails is because it can be viewed as like a relay race where the baton is passed from the basic scientists to the clinical scientists and eventually to the use of a new therapy. But I think it's much more like a soccer game. All of my kids play soccer, and if you watch a soccer game, the ball is passed back and forth. Sometimes the defense can score. Sometimes the center moves forward all the way and scores. But it's basically a process of integrative passing of the ball so that the team is involved. And I think, as was also pointed out in the previous presentation from Monica and Peter, it's very important that all the parties are involved. And so it's not too early to start to think very carefully about the involvement of the clinical development side in this really audacious and visionary translational project. The participants were Don Zach from Wilmer, Joan Miller from Mass Eye and Ear, Lois Smith from Boston Children's, and Marty Friedlander from Scripps, and a room of hundreds with a very strong level of audience engagement and questions and discussion. The outline that I'll discuss to kind of more or less summarize what happened. First, the background AG I won't really spend much time on at all. Briefly discuss one of the issues which came up, which is resuscitation versus regeneration, then get into target diseases and go into that in depth, translational issues, assessing efficacy, which will be critical for the clinical side, and then some other miscellaneous issues that are relevant to this translational effort. So the Audacious Goals Initiative, as you know, is to restore vision through regeneration of neurons and neural connections in the eye and visual system. And the goal by 2025, which is now just 9 years away, is to demonstrate the restoration of usable vision in humans. So what are the barriers to success? One is, as you've heard already, there's damaged neuronal circuitry in late-stage degeneration. That is, in most diseases, it is not just the individual neuron that dies, and that needs, in a sense, to be replaced or regenerated, but also the circuitry, the connections amongst the neurons, both the afferents and efferents, and then, of course, the efferent connections, so the double efferents, triple efferents, and so on, which also degenerate in late-stage disease. There's also damage to other local cells and sometimes distant cells that are not in the neuronal pathway, which are the glia and the vascular system. And so this idea of thinking about everything that occurs together is relevant. So, for example, in glaucoma, as you know, there is damage not just to the axons at the optic nerve head, but also the loss of the structural support. Essentially, the disc, by its excavation or cupping, becomes biomechanically quite different from a normal optic nerve head and is more susceptible to damage further on. And so, without taking that into account, without looking beyond the neuron and looking at the other supporting tissues or nutritional tissues, one can achieve regeneration, but not actually achieve a long-term result. In addition, beyond that, there's often the reparative changes that occur in the pathological state are actually anti-regenerative. So, for example, gliosis, for glial cells, fibrosis, for fibrovascular cells, is a barrier. And then, of course, there can be the remodeling of tissues that takes place. Sometimes is more than just a physical barrier, but actually a change in the way that the tissue is formed that makes it extremely difficult to regenerate. So, for example, an optic nerve for which there's been a great degree of gliosis and fibrosis may serve as an impenetrable barrier. And I think the biggest barrier to success, and the one that we spent the most time talking about, is how we assess success in human patients, which was alluded to in the previous presentation, and the difficulty when one is doing really groundbreaking research where we expect at the beginning probably a small amount of regeneration to take place, is to be able to tell that this has happened. And so that's one of the greatest barriers that we need to deal with. one of the issues that comes up is the concept of resuscitation versus regeneration. Resuscitation could be defined, and we discussed this, as preserving or regrowing damaged tissue before the point where nothing is left. That is, in the same sense that an organism, a person who may be sick, very sick, but yet not dead, it may be easier to resuscitate tissue, cells, circuits that have not yet reached that point of no return than in regeneration. On the other hand, even though it may be easier, regeneration works best when there is complete loss. So in this situation where there has been complete loss, which covers most people with end-stage blinding disease, the great causes of blindness, glaucoma, macular degeneration, other optic neuropathies, hereditary degenerations, by the time that the person has become essentially blind, lost usable vision, there probably is very little tissue left to achieve resuscitation. So that's why the regenerative approach, and again, this needs to be discussed, but the regenerative approach is probably more relevant in these kinds of cases. And of course, it's more relevant to the actual goals of the Audacious Goals Initiative. So let's get into target diseases and what we discussed. As you know, this approach that we are discussing is focused either at diseases of the outer retina, photoreceptor-related diseases, or of the optic nerve, retinal ganglion cell-related diseases. So really there's two different issues and aspects we need to discuss. So for the photoreceptors, which really is the photoreceptor/RPE complex, these are examples of three that were discussed that are kind of the heavy hitters: age-related macular degeneration, hereditary retinal degenerations, and diabetic retinopathy. And for each of them, they actually have interesting and important differences that are relevant to the strategies in terms of considering should one of these be a target disease. In age-related macular degeneration, for the most part, as you know, there are two kinds. There's a neovascular or new blood vessel type of disease, and there's a geographic atrophy type or dry macular degeneration where there's a neuronal or neuronal/RPE degeneration without the vascular component. It involves the central part of vision. In contradistinction, hereditary retinal degenerations, which typically more or less are centripetal, that go from the outer, the peripheral retina and inwards and take away vision over a long period of time in most cases, those have the reverse pattern of being more going from the outside in as opposed to macular degeneration, which is more or less in the inside. And so people who are, it's rare, for example, very less common to see complete blindness, no lack of light perception in macular degeneration, while in hereditary retinal degenerations that can eventually happen, or in some patients who have certain types of genetic disease, it can be at birth. And so the strategy one takes in thinking about how one designs a clinical study to test regeneration may be very different in these kinds of cases. Diabetic retinopathy is a third kind of case where there are many different types of loss of vision from diabetic retinopathy, including, for one side, the idea of macular edema, of tissue fluid in certain parts of the retina and actually decrease the amount of vision, but not really taking away vision completely. At the other end of the spectrum may be someone who has had such large amounts of neovascularization, of new blood vessel formation, bleeding, fibrosis, and tractional retinal detachments, essentially changing the structure of the retina, taking it off its supports, that over a long period of time may result in complete loss of vision, but at the same time mean that the scaffold on which one will try and build the regenerative cells may be very different. And so the different diseases have a big implication on how one will test your regenerative strategy, because in the differences in what parts of the retina are involved, how far along it is, and is there a scaffold there, are different. With retinal ganglion cell diseases, the issues are somewhat different. In most of the retinal ganglion cell diseases, the structural changes are very similar, except for the case of glaucoma. So in glaucoma, as I mentioned before, and we discussed how the loss of the tissue, the supportive tissue at glaucoma, is quite different from the gliosis, the increased number of glial cells at the optic nerve head that occurs in most of the other types of optic nerve diseases. Glaucoma is the most common optic nerve diseases and the most common cause of blindness actually in the world, irreversible blindness. But all the other diseases have their own advantages and disadvantages for being considered as a target therapy, as a proof of principle for the Audacious Goes initiative. So for example, in anterior ischemic optic neuropathy, there's two kinds. In both cases, there's infarction, like a stroke of the optic nerve head. That has the big advantage that after a certain length of time has gone by, it's very unlikely to improve. Most patients with AION, this stroke of the optic nerve head, most of those patients don't have complete vision loss, although there are some with a certain type, about 10%, that have it so severely that they would be very good candidates. In labor hereditary optic neuropathy, the most common hereditary optic neuropathy, there again can be severe loss of vision, usually in the central part. However, some of these patients spontaneously resolve. So it depends on the kind of genetic mutation that they have, but it can range from about 5 to 45% will spontaneously improve months to years later. And so one can argue that those might not be a good candidate for studying because of the spontaneous resolution will confuse the question of whether the regenerative strategy has been the cause or whether there's something else that the cells have brought in, a trophic support or something else that has improved things. Similarly with dominant optic atrophy, which doesn't spontaneously improve, but however does have the same pattern of loss as the labor hereditary optic neuropathy. Traumatic optic neuropathy, which came up for discussion earlier, has some advantages in that it's an acute injury where after a certain length of time, it can be fairly clear that one is not likely to see spontaneous resolution. The other part of it is that the damage occurs at a localized area fairly far away from the eye, usually in the optic canal where the optic nerve enters the skull. And so in those kind of situations, there's a little bit more control and understanding of exactly where the damage was. Most of these patients have unilateral optic neuropathy. The ones I've mentioned so far, except for perhaps about 80% of patients with AION have bilateral optic neuropathy. And then toxic optic neuropathies and then many other optic neuropathies that we discussed are also possible candidates for this kind of approach, each with their advantages and disadvantages. So it makes the whole kind of battlefield strategy very different depending on which type of disease one wants to look at and the specifics of the disease itself. Beyond that is yet another question, which is, does one look early versus late in the disease? And so this was a big topic of discussion at the town hall. So early disease has some advantages and disadvantages. The big advantage is that the guidance structures, the scaffold, is often not changed as much early on than late. Now, as was pointed out by Dr. Zarbin, yes, indeed, there are very early changes that occur in almost all of the situations at the cellular level. But in terms of let's say, the response of other tissues, the fibrosis, the gliosis, the loss of connecting cells, it's usually less early on than late. And that makes a big difference. Because if you have less tissue response, you have more opportunity to put a cell in, have it regenerate, or have it differentiate into the cell you want if it's an endogenous cell, and then extend its axons, extend its dendrites, make the connectivity. You're dealing with less variables in that situation. On the other hand, late disease has its advantages too. And as you can tell, we're not going to come to an answer today, but these are the important issues that came up at the town hall. The late disease has a big advantage because it's easier to detect an effect if you've taken someone who has very advanced disease and for which you know that the likelihood of improvement is infinitesimal. Unlike early disease, where often early in the course there can be some response or some reversal. There are also probably less safety issues when you look very late in disease, when somebody has lost so much vision that if the therapy turns out to have an adverse effect and you've lost vision from the therapy, you are less likely, that margin of injury, margin of safety is, you have less to lose, so to speak, in a late disease state. And these are things that need to be worked out as the process goes on for the translational program. Finally, the loss of afferents and efferents, which are referred to for early disease. By the time you get late disease, those are usually fairly far advanced. In the case of glaucoma, we know that with glaucoma, you lose the connectivity and the loss of algae or shrinkage of algae neurons, and in some cases, you can also see this at the level of the visual cortex. So these disynaptic effects, transsynaptic and disynaptic effects in late disease are relevant. The third area is the genetic versus acquired disease. And each of those have advantages and disadvantages. The genetic diseases are often fairly symmetric. And so that has an advantage because it may be more predictable. There may be more of a control, a more understanding of what you do in one eye and how it compares to the other eye, and what to expect over time. The other disadvantage, or rather I should say advantage to genetic disease and the disadvantage to acquired disease, is that the acquired disease may not have the same problem as in the genetic disease if you can fix the problem. So for example, someone who has lost vision from glaucoma because, let's say, that the intraocular pressure was very high. They were treated, but it was too late, and they lost vision. They had previously lost vision. Now they've stabilized their vision. You can control the pressure, and therefore you do not expect the vision to come back. In a genetic disease, the inherent defect may still be there. And of course, it depends on the disease. But for example, if someone has a specific damage in the retinoid cycle that led to their loss of vision, if you do endogenous replacement, the genetic defect may still be there. And so it's just something to keep in mind, that the genetic defect may have the disadvantage in some cases, and any other case that's due to some, let's call it inherent defect, those are going to skew how one does the study, because the defect may still be there even after the regeneration. A fourth area is acute versus chronic diseases, which overlaps, of course, with early versus late. So the acute diseases preserve more supporting structure, similar to looking early in somebody's clinical path, and but it may also reverse. It may reverse because in some cases, there's endogenous recovery in many, many different diseases. And for example, traumatic optic neuropathy looking very early on may reverse. Ischemic optic neuropathy from the NEI-funded ischemic optic neuropathy decompression trial, they saw 43% of subjects improve their vision by 3 lines or more over 6 months. So certain acute diseases, which we know happen very rapidly, still can reverse when looking later on. And so this is important unless one really knows the natural history very carefully, in great detail. The disadvantages of chronic disease, as mentioned before, and it's similar to what happens in late disease, is that the long-term effects of the disease process may lead to various kinds of fibrotic or gliotic changes that are irreversible. Similarly, the changes in the afferents and efferents. Unilateral versus bilateral disease. So as this overlaps a little bit with what I brought up with genetics, the bilateral has a little bit few less safety issues in the sense that somebody, let's say, who is bilaterally completely blind, they have less to lose early on in doing a study. There also is an inherent control because now you have 2 eyes, and if there is, let's say, some kind of an effect, if you do your study carefully, you have the other eye, the contralateral eye, serving as an inherent control. One can also argue that a bilateral disease, there's more effect on quality of life, that somebody who's already lost vision completely or to the same degree in both eyes, they, in a sense, may benefit the most from a certain increment in improvement in vision from a regenerative strategy. On the other hand, one can also argue, and this came up at the meeting, that a patient with a unilateral disease may have a greater motivation for being in an experimental treatment because they now know what they're more concerned, rightfully so, about losing the vision in their so-called good eye. And so these are areas which really overlap with certain ethical issues that are relevant, again, to choosing the disease and at what stage one does it. Beyond this, we discussed translational issues. One is, what are the target cells? And I don't want to spend too much time that overlaps with what you just heard from the wonderful presentation from Peter and Monica. We have to decide, in some diseases, it's more important to target photoreceptors, if they're photoreceptor endogenous problems versus the RPE. In some cases, both are gone, and one has to come up with a strategy to deal with that. In retinal ganglion cells, you already heard about the very marked diversity of retinal ganglion cells, both structurally in terms of where they are in the inner plexiform layer, how they act functionally, and many other features. But then one also has to consider, in many diseases of the optic nerve, that the glia are also changed. Either they become, there's gliosis, or there's actual loss of supporting tissue in those diseases. And then, especially more so in the optic nerve diseases, but even in some of the photoreceptor diseases, one has to consider not just the cell body replacement, but of course the actual axonal replacement and regeneration. And for optic nerve diseases, this is a big barrier because you may replace the retinal ganglion cell, you may have it extend an axon, but it has to it has to make its way through the optic nerve head, through the potentially inhibitory environment of the damage in the optic nerve, make its way through the chiasm, and then make its way to the appropriate target areas. And the loud geniculates would be probably most relevant to functional vision in the human. And so these are big issues that need to be kept in mind and are important for translating from this laboratory to the clinical venue. Other translational issues that came up at the workshop, the town hall, were the choice of animal models. There are no good animal models for some diseases. They really differ. Some of them have been recently come about, for example, in labor hereditary optic neuropathy for the 11778 mutation. There's some that are obviously more clear, for example, traumatic optic neuropathy. In glaucoma, there's some excellent intraocular pressure models, especially in the non-human primate, but it differs depending on the disease. And the differences between models in general, if you look back at preclinical research translated to the human realm, small differences between models often give very different results when one looks at therapeutic strategies. This kind of chaotic behavior is a real problem, and the reason is because if there's a difference between an animal model that is relatively small and leads to a big difference in results, what happens when you translate it to a human? You may see differences in results that are even more severe. And so this is an issue that needs to be kept in mind. And finally, the question comes up is how relevant is the choice of model for some of the replacement therapies? That is, does it matter in the animal whether the rat or mouse lost vision from trauma or ischemia or inflammation if the goal is to first do that first proof of principle to be able to replace the ganglion cell and get it to extend its axons? And so this is a kind of an open question. A lot depends upon what's left on the battlefield after the pathophysiological damage has taken place in the animal model and in the human model. Another issue related to translation is the choice of the species. So we know very well that there are big species differences in almost everything you could look at. So I mentioned a few: differentiation, immunology, and function between mice and rats and non-human primates and humans. It's huge. And we all know that this is important not just because will we have an efficacy translation, but will we have a safety problem? And I don't want to have to bring up the history of phase 1 clinical trials where a drug that was very safe in a variety of animals can sometimes lead to unexpected effects in humans. And the same thing may be true for these kinds of therapies that we've been discussing at the AGI. So we have to, again, keep that in mind. The other issue is especially for things related to photoreceptor diseases, that rodents don't have a macula and they don't have good vision. You already heard about zebrafish and their vision. It's not that we can't do these things, but it makes it more difficult. And so, again, this is relevant to the progress of it. Assessing efficacy. There's safety studies and efficacy studies, and this was a big point that was brought up at the meeting. Safety studies, where we just want to make sure that we're not going to make things bad, those can be done in end-stage disease. Ideally, the very first safety studies would be done in people who are completely blind. I think there was general agreement with that. Efficacy studies do not necessarily have to be at the end stage, although they may well benefit from being at the end stage, because one can assess the difference, the effect of the treatment better in someone where you're starting from a very low amount of vision. Another issue came up with efficacy is, was it regeneration or some other effect of the therapy? And this, the idea of paracrine effects or trophic rescue from your cells that you've either exogenously or endogenously changed. These types of factors can be diffusible, they can be cell-directed, and can be confusing in the analysis of the results. One of the ways to attack this is the role of imaging. And I want to bring up here what is, I think, a very important part of the AGI, which is the emphasis on imaging. Imaging, and I'll bring this up in a subsequent slide, imaging is critical to being able to tell what actually happened. Because at least you were able to see, in the same way we saw with the presentation of Jeff Goldberg's the study, where you could see the ganglion cells themselves extend their way all the way up the nerve. If you can see the same thing in the human, that the cells that you've transplanted are actually gone somewhere, that gives you some more confidence that there's an effect. The other issue that comes up with, was this regeneration or something else, is the role of disease variability. Getting back to the idea that there sometimes can be reversal, there sometimes can be worsening. Diseases are variable, and clinical assessment of function are highly reversible in people. And so this is something that needs to be kept in mind. So the endpoints, there's structural endpoints, functional endpoints, and endpoints that actually have a combination of both. So structural endpoints, are there new cells there? Are there new axons there? Are there new connections there? It's possibly more sensitive. That is, structural visualization is often thought to be more sensitive, although there's some counterexamples to that. But in general, one can pick up small numbers of cells more easily than small numbers viewed in a functional sense in a person. It's also possibly, but not always, less variable. That is, your assessment of do you see a cell or not is more or less kind of a binary question. Well, is there function or not is often overlaid on the noise of clinical assessment. So are there new cells? This is where the AGI imaging component comes in, the direct imaging of cell bodies. This is more appropriate in the retina. Is there thickening new axons in the nerve fiber layer? You can look in the optic nerve head and use techniques such as diffusion tensor imaging, DTI, to see are there new axons that go down the optic nerve. And one can use reporter proteins. This is done routinely in animals to tell us, yes, there's a new cell, it is there, and it is the right kind of cell. However, in people, there may be some ethical and safety issues about reporter proteins. In functional imaging, it's more relevant to the patient. The patient doesn't care, did they get a new cell? What they care is, do they see better? It's probably more variable, because most functional assessments are more variable. The nice thing is, and this is, again, a component of the AGI imaging initiative, is it's possible to image function in cells and axons. Look at metabolic changes. And these are some examples of how this can be done. One can actually look at connectivity to afferents and efferents based on functional imaging, looking at activity-dependent metabolic changes, looking at target functional changes. And I won't go into the detail, but this is a big part of the AGI imaging. And I think it's very important for distinguishing, do we just have structural recovery or functional recovery? To finish up, other issues. There's an ethical issue in how we do this. Not that it's a problem, but we need to pay attention. This was already raised in the previous presentation. Who should be participating in these early stages? When I say the early stages of the program, not the early stage of the disease. How do you provide hope, but not false hope, to someone who's going to participate? Because at the very beginning, we really don't know whether this will be effective or not. And of course, there are always risks in safety studies, and so the subjects who are participating need to understand that fully. The final issue is the FDA and therapies, because eventually, when this works, there will be a partnership that will be necessary, because this will be developed, hopefully, and become, once one of these therapies starts to come into practice, it's going to be a partnership with industry. And we know that how the FDA looks and approves new therapies is based on clinically significant or clinically meaningful changes. And so we have to kind of keep that in the back of our heads, is what is going to happen and what's meaningful to the patient. It's different from a proof of principle study where we just want to, at the beginning, know, does this work or not? In summary, testing regenerative therapies in thoughtful and feasible clinical trials is going to be completely critical to the success of the Audacious Goals Initiative. The preclinical advances, number one, the new imaging techniques, number two, and the translational design, what we discussed at the town hall, they make up the necessary triad for achieving AGI goals. Thank you. No discussion?
Well, the imaging thing, I think, is a big deal because it allows you to have an iterative pathway to success. So, so of course, the patients want functional improvement, but that's not going to happen. Whereas you can see incremental improvement with appropriate imaging technology. And I almost would say that's a sine qua non, a prerequisite before proceeding with the clinical trial. Another point that I think is worth thinking about, because I'm going to suggest that you think about who should be sitting around the table when you're making go, no-go decisions. So the background for this is the bilateral versus the unilaterally blind person. I've learned, and this is very surprising to me, but I've learned that there are two kinds of biases in clinical trials. There's allocation bias, and there's ascertainment bias. Now, ascertainment bias can be handled by double masking, which is impossible in a surgical trial, basically. But fortunately, the failure to double mask only leads to an overestimation of treatment benefit by a number that's close to 20%. But the allocation bias leads to overestimation of treatment benefit, according to this guy named Schultz who studied this, by anywhere between 30 and 40%. And allocation bias is usually handled by concealment of allocation, at the selection bias. And so I'm very worried that a unilaterally blind person is the wrong candidate precisely because of this. But that's something that's out of my area of expertise. But what it makes me realize is that in addition to an ethicist, I think you need a person with the right clinical trial design background to help.
No, I completely agree. And your point is going, it was actually because it was raised at the meeting, one person brought up the unilateral versus bilateral, and then we had a little panelists, we discussed that, and I think everybody would agreed with you that. But again, right now we're at the very, very earliest stages, and your point about having trialists, not just ethicists, but trialists as part of this is really critical.